Welcome to Medical Matters Weekly with Dr. Trey Dobson, presented by Southwestern Vermont Healthcare and Catamount Access Television.
Today is October 22nd, and we have a live show today. I'm Trey Dobson, Chief Medical Officer at Southwestern Vermont Medical Center and an emergency medicine physician with Dartmouth Health. And this is Medical Matters Weekly, a show about the aspects of healthcare that matter to you most. It's almost Halloween, and I am so sorry to say I forgot this morning about the show and almost Halloween. I should have dressed up. I should have asked my guest to dress up, but we did not do that today. My guest is Dr. Matt Staniszewski. He is a rheumatologist right here in Southwestern Vermont Healthcare in Bennington, works for Dartmouth Health, and has been with us. How long have you been with us, Matt? 5 years, 6 years?
It's actually been 7. This is my 7th year.
7th year.
Yeah.
Dr. Staniszewski earned his medical degree from the Philadelphia College of Osteopathic Medicine, completed a fellowship in rheumatology, which is the subject of our discussion today, at Roger Williams Medical Center, Rhode Island, and he's a fellow of the American College of Rheumatology. So where are you joining us from right now, Matt?
From my office here on campus.
Great, in Bennington. This is fantastic.
Yes.
Many of our recent guests have been outside of the state, and it is so great to have you here with us. So before we get into rheumatology and sort of what that's about and what illnesses you treat and how you treat them, I just want to learn a little bit about you personally. Of course, I know, but I'm going to share that with the audience. Tell us a little bit about where you're from, where you grew up, and then how you got into medicine in the first place.
Sure. So I'm originally from Eastern Pennsylvania, just outside of Philadelphia, in a town called Downingtown, and I grew up there. Spent my college career down there. After high school, I went to Temple University, stayed in the city, and then afterwards, after a year of working in the fields, ended up pursuing medical school in that city as well. And it's as far as how did I think about getting into medicine? It was kind of an interesting story. I had some medical issues as a child, and I didn't handle them very well, and I developed this real fear of hospitals and actually blood, and I just couldn't handle it. And at some point in high school, I said, I really think this is interesting. I don't know if I'm going to be able to jump this hurdle. I might as well immerse myself in it. So I found out that there was a class that they were offering through the Votech that allowed me 2 days a week to go and rotate with some physicians at the local hospital. And that turned out to be a kind of a life-changing experience for me. And afterwards, still had a lot of issues with my former fears, and I just started to immerse myself and got a job in the ER. And real quick, I got over my fears, interestingly. And the rest is history. I pursued pre-medical studies and actually a physical anthropology degree at Temple University, and then medical school thereafter. So
that is a really interesting story. In fact, I haven't heard that one in a while. In fact, I may have only heard a background like that once or twice. Most people gravitate towards medicine because it's either in their family or they have exposure and they find it interesting. And yours was almost the opposite. You recognized a fear and said you're going to take it head on. And wow, you're a practicing physician, which is remarkable.
Yeah, it was a pretty strong. There was a pretty strong fears too. So I'm just as surprised as you. But...
So how did you then choose the specialty of rheumatology?
So just like most I think medical students, when you're in medical school, you kind of like everything for a little bit until you don't. And the folks that like a little bit of everything might gravitate towards doing an internal medicine residency, which is what I did. And was about a year and a half into my residency there that I had the opportunity to have a few cases that were directly involved with rheumatology, and got to spend some time with some mentors, and really turned me on to the subject because it really encompassed a lot of different specialties altogether, and also was I kind of naturally gravitated towards enjoying treating musculoskeletal conditions anyway, and it was just turned out to be a perfect fit.
You know, for those in the audience that, to clarify, I know many people know this, but medical specialties like rheumatology that Dr. Staniszewski is in, also cardiology, gastroenterology, they all go through a at least 3-year residency in internal medicine, and then go into their specialty fellowship. Dr. Staniszewski would have done a 3-year internal medicine residency, followed by a 2 to 3 year fellowship in rheumatology. So describe, you mentioned musculoskeletal. Describe to us what rheumatology is for folks that are unfamiliar with the term.
Yeah, so I think rheumatology is kind of a black box. Folks really hear the name and say, what is that? I have no clue at all. So what this is the study of inflammatory diseases that affects the joints, the muscles, the bones, the connective tissue, as well as the internal organs, and how that interacts with the body's immune response. So we deal with disorders that may affect anywhere from just the joints to the lungs, the glands, the gastric tract, and the kidneys, and we work pretty closely with other specialists in those fields to come up with a quality plan for patient care.
So when, I think most people recognize what the immune system is, at least in general, and even what an autoimmune dysfunction might be, where the body's immune system, including the cells, are overactive and start not only attacking what they're supposed to, but doing damage to things they're not supposed to. And there are many diseases I know that you treat, and we're going to ask that question in a minute, but can you just give us an overview? You may want to pick lupus, anything you want to pick, and rheumatoid arthritis, and just sort of walk us through the basic science, not in too much detail because you'll overwhelm folks like myself and others.
Sure. So I'm a simple person. I have to make things simple for myself to understand them. So how I usually explain this is we have a condition. Let's say it's rheumatoid arthritis, and someone may have an underlying set of genetics that may place them at risk for developing this at some point during their lifetime. Now, I'm not saying everybody's genetics are the same that develop rheumatoid arthritis, but they may share a specific set of genes that may just sit there and wait, okay? And they're kind of primed and waiting, and they may be turned on, they may never be turned on. Some folks who have this kind of genetic makeup may go their entire lives without developing any kind of inflammatory condition. But the way I usually describe it is that they sit there and they wait, and then something in the environment, such as an allergen, or let's say a bacteria or a virus, or it could be a very stressful reaction, something that really sparks the immune system to come alive, okay? And that is the tipping point for some of these genes to start to turn on. And once they turn on, they just don't want to turn off, And sometimes they do turn off, but sometimes they don't. And when they don't, conditions like rheumatoid arthritis can start to flourish. And when they start to come on, they start to become more of a chronic condition that does not want to go away. So our focus there is to try to settle down the inflammatory process the best we can, especially when it turns into being more of a chronic process.
So these are immune cells that are, in a sense, sort of attacking the linings of the joint. And is that how you would describe just basically rheumatoid arthritis?
Essentially, yes. I mean, we have the innate immune system, which is kind of our immune system that is kind of pre-programmed, that we're born with, and then we have our adaptive immune system, which is are the cells that create antibodies and react to what we've been exposed to during our lifetime. Kind of like a virus. When you get a virus, you have cells that create antibodies. So the next time you see that virus, your body sees that virus, it's easier to fight off. But now we're dealing with these same cells that are creating antibodies that are creating them against your own tissues, and that can be anywhere from the joints to linings of other organs in the body, and that's why we see sometimes even in rheumatoid arthritis, it's not so simple to say it's just the linings of the joints, because we do know that other organ systems can be involved as well, and it's more of a systemic process than just saying that it's involved in the joint.
And I think that you're right on there in bringing up the joint. I think a lot of folks, just by their experience, think of a rheumatologist as dealing with osteoarthritis and then maybe rheumatoid arthritis, but don't realize the breadth of other organs that can be involved. Tell us about one more condition before we go into the treatments. For example, you see lupus, you see other autoimmune type disorders.
Yeah, correct. So lupus is a multi-system disorder that is I still when it comes down to when I explain that type of condition, it always comes down to the basic notion that there's a certain set of genes that are underlying this, and something is there to turn it on. And again, once it turns on, and when it comes to lupus, it may be there may be maybe many more systems involved than just the joint. Let's say the kidneys, the lungs, the skin, and when it does occur, it can be quite profound. So these are conditions that you really want to start treatment early before they cause any kind of long-lasting damage to the tissues.
So we can move, you talk about starting treatments. I know that treatments have certainly progressed starting about 25 years ago. Before that, there wasn't a lot that could be done except steroids. You were almost like a dermatologist here, take some steroids. But that's not the case today. So why don't you tell us a little bit about some of the treatments?
Sure. We live in a very, very exciting time, not only for rheumatology, but for other specialties as well. And this really is just every month that goes by, there are new studies coming out about proteins and molecules that are being augmented and learned about more, so that we can craft specific medications targeting the very smallest levels. We're targeting these molecules that if you take away one of these molecules or you block them, okay, the inflammation just never has a chance to occur. Or if it's already occurring, the inflammation just kind of falls on itself. And it's very, very interesting time. I think that this is just kind of the tip of the iceberg, what we're seeing over the last 25 years. And really, you're correct. You know, the treatment for rheumatoid arthritis really was somewhat reached kind of a stagnation through into the 90s, where we had a few things that really worked, but for the folks that they didn't work in, we had nothing else. And now we have very targeted and focused therapies that we and many more options, so that folks that may have been told in the past, you know, where we would have said, listen, you know, we don't have anything else, we're going to do our best, but these are the medicines we have. Now we have many more options, and we see much less people with disability now than we did.
And are most of these treatment options monoclonal antibodies? Are there other treatments that are on the horizon?
No, I think it's more than that. It's combinations, and we're still. It's not like we have abandoned our older therapies.
Mm-hmm.
Okay, those therapies still work well for sometimes a majority of the population, and which is why we really a lot of times we'll start with those. But it's for the people who those therapies don't work in, okay, that the more advanced and newer therapies are very helpful. And you know, it's not just monoclonal antibodies. We have we're finding different ways in which we can target these small parts of the immune system. Okay, if we just target that one spot, then like I said, the inflammation process just never has a chance to occur. And the study of these immune processes has gotten so in depth and more complicated over the years, let's just say, that it's difficult to capture in sitting here talking to you, but it's certainly exciting.
I mentioned earlier dermatology. I'll just point out for the audience that Dr. Staniszewski, rheumatologist, accepts patients here at SVMC and works very closely. It's interesting the overlap that these inflammatory disorders can have with dermatology, for example, and Dr. Alicia Ellis, even infectious disease with Dr. Marie George, gastroenterology with Dr. David Furman, and others, that you almost have to align your treatments together. I know patients may see two specialists at once. How do you communicate a treatment plan when you have more than one specialist involved?
Well, I think it's just taking the multidisciplinary approach, but I'm old-fashioned, so the one-on-one collaboration with these other specialists is extremely important. Having the conversation, and if it's more than just me and somebody else, then we get all three of our heads together or four of our heads together. And the nice thing about having an institution like ours is that it's extremely easy for us to communicate. And another nice thing is that with our collaboration with Dartmouth has been very useful as well, as we work on cases together, and the communication has really been seamless for most of us.
Yeah, I'll also say, echoing that, you know, all of those physicians I just mentioned are excellent, and then the relationship with not only Dartmouth Hitchcock Medical Center, but other physicians in our entire Dartmouth Health System. It's really important because frankly, physicians pretty much think alike around the country, but when you go to different areas and there's not familiarity, that communication is not perfect. Sometimes balls can get dropped, and that's why it's important to advocate for yourself, but also make sure you're telling your doctor everyone else you're seeing and make sure they're in collaboration. And that's much easier to do if you're in one single system when possible. Tell us, do you have some rarer conditions that you don't see often but are interesting that you find in your practice?
Yeah, so most of what I see is more what we call well, I guess well, most of what I see is going to be more common conditions, but occasionally I do see a case that might maybe you've only kind of read about, and those are challenging, but very very rewarding as well. So this would be a condition like Cogan's syndrome, okay, or an autoimmune eye and ear syndrome, or an auto-inflammatory syndrome that are conditions that are just very very rare, unless you're in a patient population that has that lends itself to those conditions occurring more frequently, and they may be more seen in inner city practices more than rural practices, but we still see them, and it's very it makes my specialty just all that more interesting. But again, it can be challenging as well. So.
Yeah. What are you looking forward to? Let me start with the personal question. I didn't even get a chance to ask you what you do outside of medicine, so I'll do that now and ask you what you're looking forward to personally over the next 1 to 2 years.
Sure. So I am an avid outdoor enthusiast, and so is my wife. So she always keeps me on my toes, and so we enjoy camping, hiking, or skiing in the winter, kayaking during the summer. We are and our 2 kids are keeping us busy every single day of our lives, of course. So we're quite busy outside of the office here, and as far as looking forward, as far as personally, just watching my family grow has been, one of the joys of my lifetime. We really, it's just fascinating, and with the recent pandemic, it has been, well, let's just say sometimes it's easy to lose sight of those things sometimes, but you really come around full circle when you have these things happen in your life that may take away from your livelihood. So in the next few years, I'll be looking forward to serving my community here at SVMC, watching my family grow, and I'm always reading. I love to learn new skills, and I'll be taking on. I'm sure I'll be taking on more projects that take me outside of my comfort limit. And more recently, I've been trying to become more comfortable with working on cars and seeing how all that works out instead of the body. But so that's what I've been focusing on in my free time.
That's fantastic. I should have pointed out in the very beginning, and I'll just do it now, that Dr. Staniszewski is also the chair of internal medicine at SVMC and the vice president of the medical staff, which means he will assume medical staff presidency here in about a year and 8 months or something, if I'm counting that correctly. Thank you so much for joining us today on the show.
Thank you very much.
I'll also thank Mike Cutler from CAT TV, Ray Smith from Southwestern Vermont Healthcare, and Ashley Jowett from Southwestern Vermont Healthcare. I'm Trey Dobson. Go out and find joy in everything you do, even in the face of adversity, and we will see you again next week.